أهل اسكندرية، أهل جميع محافظات الوجه البحري والقبلي في جمهورية مصر العربية، ولو في أي حد وصل من الانترناشنال وجيفاني وفي سينا كمان. طيب يعني داخل الجزيرة وخارج شبه الجزيرة المصرية. ومرحبا بأهل المنصورة والحمد لله على السلامة. معلش احنا اتأخرنا شوية نظرا لظروف الطرق. احنا بدأنا بعون الله الجلسات العلمية بتاعة المؤتمر والجلسة الافتتاحية أمس، وكان يوم حافل، وإن شاء الله النهاردة هنوعدكم بلقاء علمي متميز، مجموعة محاضرات فائقة المستوى. برحب بزمايلي في البورد في المنصة، أستاذ دكتور أشرف طلعت، أستاذ البطنة والسكر والكلى في طب بنها، أستاذة الدكتورة غدا الخنيشي زميلتي العزيزة معايا في وحدة النفرولوجي مستشفى المنصورة الجامعي قسم البطنة العامة. برحب بكم جميعا. الدكتور طارق، معلش شفتك طارق، دكتور طارق دكتور طارق طنطاوي استشاري الكلى في المحلة وزميل عزيز من المنصورة برضه. ان شاء الله الجلسة العلمية الأولى يعني وي هوب ان هي فيها 5 محاضرات. هنبدأ أول محاضرة
هيكون في رقم هيظهر قدامنا دلوقتي على الشاشة، ده رقم واتساب اللي له أي سؤال من الفلور ممكن يبعت عليه، والسبيكر إن شاء الله هيجاوب في آخر المحاضرة. ديسكشن في آخر السيشن.
احنا معانا أول سبيكر دكتور أحمد السعيد، من الدكاترة الصاعدين الواعدين، مدرس أمراض الكلى في وحدة MNDU في المنصورة، وهيتكلم على الكدني in the era of direct acting antiviral drugs. اتفضل يا أحمد.
بقلب من تحت كده. لا خلاص، ما عمال ما تركبوها اهي. بسم الله الرحمن الرحيم. Kidney in the era of direct acting antivirals, the last lines of the story. Before reading the last lines of the story, we have to pass through 2 chapters of this story. The first chapter is the nephrotoxicity of direct acting antivirals. Actually, our story started in the early 2014 with the introduction of sofosbuvir as direct-acting antiviral for the treatment of HCV. The problem with the sofosbuvir was that 80% of the drug is urinary excreted or excreted through the kidney. The second problem, that after introduction of the drug, we started to see cases coming with acute kidney injury after taking the drug. So some questions started to appear. The first question, does this drug cause acute kidney injury in patients with normal GFR? Is it safe and effective in cases with chronic kidney? And the last question was about the use of ribavirin in chronic kidney patients. The first study was presented by Man et al. From Montero to study the effect of sofosbuvir in patients with normal GFR. The sustained virological response was 85%, but he defines acute kidney injury as the rise of serum creatinine by 0.3, and there was 11% of 120 patients in his study, but these patients have elevated serum creatinine even after the stoppage of the drug. Another study showed that there is acute interstitial nephritis in patient presented with acute kidney injury and taking sofosbuvir. One of the important studies and one of the landmarks is the HCV target study, which presented by Saxena et al. In this study, they had patients with divided the patient into patient with GFR below 45 and above 45, 1,800 patients above with GFR above 45 and 82 patients with GFR below 45. They have sustained virological response ranging from 80% to 100%, even in patient with GFR below 45. But there was worsening of the renal function in patient with GFR below 45 in 11% in 15% of the cases. In our experience, in our unit, we conducted one study, which was prospective observational study. 280 patients, 140 received the sofosbuvir regimen, and 140 received a combination of baritabravir, ritonavir, and opicinavir. We have a sustained virological response of 95% in patient taking sofosbuvir regimen and 100% in patient taking Curivo or the other regimen. On studying the occurrence of acute kidney injury, we also define the acute kidney injury as elevation of serum creatinine more than 0.3. We have 21% of the cases with elevation of the serum creatinine. But this elevation of the serum creatinine was transient during the treatment, and the patient returned to the basal level of creatinine after the treatment, and it was transient. After this, there comes the presentation of the combination of ombitazvir, baritabravir, and ritonavir plus or minus ribavirin in the 2015, and comes the Ruby study 1 and Ruby 2, and also other studies to say that this drug is effective in patients with severe renal impairment and end-stage renal disease, and even in dialysis patients with no side effect. So the easy recommendation in 2015 come to say that the sofosbuvir not to be given to patients with GFR below 30, and that other drugs, including the combination with baritabravir, ombitazvir, and ritonavir, can be given for patients with GFR below 30, and this was taken by the Egyptian committee, and this is the regimen now used in Egypt. After this come the Sea Surfer study, which said that grazoprevir plus elbasvir had also a good effect in patient, and the sustained virological response was 99%, with no effect or deterioration of the GFR. Although this study contained 81% with GFR below 15. After this comes the era of the pan-genotypic drugs like glycaprevir, bebrentasvir, which was given for the patient through the expedition study, and so showed that this drug were safe in patients with severe renal impairment. According to these studies, the American Association of Liver Disease and the European Association come to recommend in 2018 to give patients with GFR below 30 the elbasvir grazoprevir combination, zabatir, and to give glycaprevir, bebrentasvir, maviret for patients with GFR below 30. And finally, the KDIGO guidelines that released in late 2018 also recommended for patients with genotype 4 that is commonly in Egypt to give grazoprevir, elbasvir, and glycaprevir, bebrentasvir. But comes the last question in this chapter: whether ribavirin use in CKD patient was safe or not. Again, back to the HCV target study, which is an important study. The anemia occurred in patient with GFR below 45 was 30%, and required transfusion in 10%, and the erythropoietin use was in 12%. Also, the ribavirin was discontinued in 12% of the patient, which indicates that ribavirin maybe has a hazardous effect for the patient with GFR below 30. Again, the study came in, this study was published this month in the Kidney International Report about the Curivo use with or without ribavirin. Here we can see patient with CKD 1, 2, and 3, and there is and its use with ribavirin. There is severe the most decrease in the hemoglobin level was in CKD stage 3 patient with the use of ribavirin. And finally, the KDIGO guidelines recommended that patient with GFR below 30 better not to take ribavirin containing direct acting regimen, and to take ribavirin free like isabaptir or mavorixafor, gilacapavir, bebrentasvir. This table can summarize that sofosbuvir is renally excreted, so it is not recommended for patient with the GFR below 30. Semiprevir, lidibasvir, valbatasvir, daclatasvir are not contraindicated, but they should be given with sofosbuvir, so its use are restricted. For baritabravir, ritonavir, and umbitasvir, this combination can be given for patient with GFR below 30. Elbasvir, grazopravir, isabaptir can be given, and also gilacapavir, bebrentasvir. Now to the second chapter of this story, the HCV nephropathy and direct acting antivirals. After the previous data, the drugs become available to use for HCV nephropathy patient, and many studies were published through 2015 to 2017, and even there are more studies. These studies showed that the sustained virological response was very, very high, and the results were very optimistic. It started from 80% up to 100%. And at this time, we thought this was the happy end of this story, that the patient now can take the drug and become cured from HCV nephropathy. But unfortunately, this patient, the patient the patient with HCV nephropathy that takes the treatment and become cured from HCV with sustained virological response 12 weeks after the treatment, have persistent disease. Even we can see recurrent cases, and even the surprising was that we can find de novo cases. So we have to search through the literature for this and answer these questions. Is it really persistent? This study in 2018, it included about 180 patients, and 9 of them had HCV nephropathy, and showed that the proteinuria was persistent in 67% of the cases. Rutledge et al. Summarized the data from the studies from 2015 to 2017, including HCV nephropathy cases, and showed that a lot of cases had, if we can see here, that the glomerulonephritis resolved in 0%, here in 0%, here in 0%, and here in 0%, and here in 30%. So the disease is persistent and it's not cured as we thought before. And he finally come to a conclusion that although or despite the sustained virological response was very high, 95%, the full clinical response and the full immunological response was only 50% of the cases. So we have another 50% with persistent disease. In our experience in our unit, we have a study about the nephropathy group, 34 patients, 30 of them had renal biopsies, and 85% of them were MBGN. These patients were given direct acting antiviral, and the response was 97%. And despite this high response, the GFR improved only in 50% of the cases, proteinuria improved only in 40%, and the total renal response in the cases was just 50%. So we have 50% of the cases also with the case, and this was our conclusion, that the direct acting antiviral were highly effective and tolerable by the patient, but they can cure only half of the patient. And also came other reports after this to say the same, that persistent after that the HCV nephropathy may be persistent after the taking the drugs and the HCV become negative. Is it recurrent or not? This was the other question, because we have seen many cases coming with recurrence of the disease even after the sustained virological response was negative, and there was no HCV. After clearance of the HCV from the serum of these patients, they still have proteinuria and come with HCV nephropathy with recurrence. This case series showed 15 patients coming with HCV nephropathy again after the treatment and after clearance of the disease during the era of interferon and the era of direct acting antiviral, even up to 2 years after the treatment. And this one in 2018 studied about 52 patients and studied about 180 patients and followed the patient for 24 months, 2 years after the treatment, and found that 11% of the patients have recurrence of the disease. There comes the last question in our story. Can this HCV nephropathy or this extrahepatic manifestation occur de novo after the treatment of the disease and after clearance of HCV from the blood? This was a report in 2017 about 2 cases coming with de novo HCV nephropathy, and they have renal biopsy after the treatment and the clearance of HCV. Another study from Qasr al-Aini by Faid et al. Showed that they followed about 13,000 patients. They have not any signs of HCV nephropathy before the treatment, and after the treatment, they do the creatinine and the protein for the patient, proteinuria for the patient, and found that 50 patients had detectable cryoglobulins, and when they had a renal biopsy, 52% had MPGN, and 46% of the cases progressed to end-stage renal disease or CKD. And finally comes the KDIGO guidelines to say that the development or persistence of the cryoglobulinemic vasculitis after achieving the sustained virological response is possible. And this is not an imagination, it's a reality. And this may be due to the continuation of B-cell production of pathogenic immune complex after the treatment, which continue after the treatment. But how to treat? This was the question. The KDIGO guidelines recommended the use of immune suppressive therapy in histologically active HCV patients which don't respond to antiviral therapy and have cryoglobulinemia kidney disease after. Before coming to the last lines of the story, no one still can write the last lines of this story. We still have to search more and more and have more and more studies so we can write an end for this story, and thank you.